I am going to introduce our first speaker who's going to talk to us today about prevention and early detection. I would like to welcome Dr. Elizabeth Hale, who is a clinical associate professor in the Ronald O. Perlman Department of Dermatology. Let's welcome Dr. Hale.
Thank you.
Just use the arrows.
All right, thank you so much for having me again this year at this very important symposium. And I really want to give a special thanks to Jack and Maggie because they've done such amazing work over many, many years after the tragic loss of their daughter. And it's really amazing because they're getting the message out that melanoma, which is the most serious type of skin cancer, oftentimes can be prevented. And they really are about increasing awareness so we can try and diagnose this cancer at an early stage. So thank you, Jack and Maggie, for the work you do. So I'm going to start off the program. I'm a dermatologist, and I trained here at NYU, and I'm in practice now with my sister, but I still teach here every week. And I'm going to talk about the main types of skin cancer. The end of my talk will focus on melanoma, which is, of course, the most important because it can be the most serious. But the majority of skin cancers are actually known as non-melanoma skin cancers, and I'm going to talk about those first because they're incredibly common and also largely preventable. So up to 90% of skin cancers are associated with exposure to overexposure to UV radiation. And something else I see regularly in my practice as a dermatologist, that up to 90% of visible changes commonly attributed to premature skin aging are also caused by the sun. So I'm a big believer in sunscreen every day year-round because it can decrease our chances of sunburn and skin cancer, but also can limit the signs of premature skin aging like brown spots, wrinkles, etc. So I do often start with that. So overexposure, I just want to check one thing here, and I apologize. Okay, sorry. We're good. I thought maybe I had a different version of my talk. Okay. So just, I do talk to my patients a lot about this. Obviously, first and foremost, we want to try to avoid sunburns because we know that sunburn directly increases our chance for melanoma. But also, even a suntan, like when I was growing up, people thought, oh, you have a healthy tan. And now we know there's really no such thing as a healthy tan. A tan basically represents damage to our skin and can cause chronic effects like immunosuppression, aging of the skin, and then, of course, skin cancer, which is why we're here today. So as far as skin cancer, something people are often surprised to hear, skin cancer is the most common cancer diagnosed in the United States with well over 5 million cases annually. But put another way, skin cancer is actually more common than breast cancer, prostate cancer, lung and colon cancer, all combined. So it's extremely common and highly likely that maybe people in this audience have had some form of skin cancer or probably know someone who has. And that's because 1 in 5 Americans will develop some form of skin cancer at some point in their lifetime. And it's important to realize, as was alluded to in the video, this includes all skin types. So we see skin cancers now in Latino Americans, African Americans, Asian Americans. It's not just a disease of fair-skinned people, although it is more common in certain types of people, but we're seeing increases across the board. The most common types of skin cancer are basal cell carcinoma, squamous cell carcinoma, and melanoma. And really, 80% of new skin cancers are basal cell carcinoma. So they're extremely common. They're more common with age, although we're also seeing these in younger individuals. About 16% are squamous cell carcinoma. Only about 4% of new skin cancers are melanoma. However, it is accountable for the majority of death from skin cancer. So although the non-melanoma skin cancers are more common, they're unlikely to result in death. Melanoma, although it only represents less than 5% of skin cancer cases, if it's not caught early, it can be deadly. It can cause significant problems, and we'll hear about some of that from my colleagues later. So early detection is really key when it comes to all types of skin cancers. So put another way, although melanoma accounts for less than 5% of skin cancers, it accounts for 75% of skin cancer-related deaths or more. I'm going to talk first about the non-melanoma skin cancers. They are far more common and also less serious, but they're worth knowing about because they are skin cancers, and if they're not treated early, then can cause significant morbidity and occasionally mortality. So the non-melanoma, again, that's basal cell and squamous cell carcinoma, account for half of all cancers diagnosed in the United States. And it's thought that at least 40 to 50% of Americans who live to age 65 will have basal or squamous cell carcinoma at least once. Fortunately, although they're so common, Both of them have a better than 95% cure rate when they're detected and treated early. However, although they're less aggressive, far less aggressive than melanoma, they can be highly disfiguring if they're left untreated, and I will show some pictures. So for those of you who don't want to see clinical images, this is your warning because I am going to show some. But sometimes in my practice, I treat basal and squamous cell carcinoma every day in my practice, and sometimes patients say, well, if it's never going to kill me, why do I need you to cut something off? And if they're left alone, they can actually cause significant disfigurement and morbidity as well. So again, important to detect all of these while they're in an early stage. As far as the epidemiology of non-melanoma skin cancer, although we do see it in all skin types, there are certain risk factors. For example, cumulative sun exposure, which means that for basal and squamous cell carcinoma, the longer we live, the more sun exposure we get, the increased risk that we have. So therefore, they are more common in older individuals. Although again, because of certain tanning habits, we're seeing more of them in younger patients, but they're certainly more common. People who may retire to a community, like in Florida, for example, they're outside every day. They're increasing their chance for non-melanoma skin cancer. Because of their direct correlation to sun exposure, they often occur on the head and neck or the upper arms, the backs of the hands, areas that are chronically exposed to solar radiation. And they are more common in fair-skinned people with light-colored eyes, red or blonde hair, although again, we're seeing this in all skin types. So basal cell carcinoma, which as I've just mentioned, is by far the most common cancer diagnosed in the United States. So skin cancer is the most common. 80% of those are basal cell carcinoma. So these are incredibly common. We call them BCC. They do have a very low risk for metastasis, but they can be highly disfiguring by invading local tissue. And I just mentioned, although we do see more of these in older individuals, the number of women under age 40 diagnosed with basal cell carcinoma has more than doubled in the last 30 years. And a lot of this stems from the fact that a lot of young women in particular are still visiting tanning beds and tanning salons. So we're seeing a correlation with that. So the classic basal cell carcinoma starts as what we call in dermatology a pearly papule, which means a shiny bump, which often has an elevated rolled border and a crust or an indentation in the middle. Sometimes people describe this as, I've had this pimple, doc, for weeks or months, the pimple's not going away. You know, that can be a buzzword, that this could need a biopsy and could be a basal cell. As the growth enlarges, telangiectasias, which are tiny little blood vessels seen here, start to develop on the surface. So they can sort of look like cysts or pimples, but they can be shiny and have these little classic blood vessels running through them. Again, oftentimes we'll see a central indentation or erosion in the middle. Sometimes a man will come in, he'll say, I had this shaving cut on my face, it's not healing, it's still crusting, scabbing. So that again can be an indication that the lesion should be biopsied. Also, any sort of open sore. So they can start pretty subtle, you know, a little scratch that's just not healing. So we see this every day in the practice. I've had this spot for a while, it's just not going away. And so oftentimes a biopsy will reveal a non-melanoma skin cancer. Again, this is what I warned you about, my apologies, but important to realize that although they're not usually life-threatening, if left untreated, basal cell carcinoma and squamous cell carcinoma can grow locally. They can start invading local structures, local tissue. So it's better to treat them when there's still that small little pimple-like lesion on the face. And this is what I tell my patients. Squamous cell carcinoma is the second most common type of skin cancer. Again, these two together, BCC and SCC, are known as non-melanoma skin cancers. But this is the one that's most correlated with chronic sun exposure. So patients that work outside, maybe not so much in New York City, but in the Midwest where there are a lot of farmers or where there are people who work outside on boats, people who are exposed every day are much higher risk for squamous cell carcinoma. And this is the one that cigarette smoking is also correlated with. So for example, on the lower lip, and I'll show some pictures, there's the chronic effect of sun exposure, because even walking around Manhattan on a day like today, our lower lips are exposed, combined with the effect of cigarette smoking can trigger squamous cell carcinoma. Squamous cell carcinoma, in addition to sun exposure, sometimes also occurs in the setting of burn injuries, scars, and there's a virus called HPV that can lead to genital warts and issues like in the cervix. This is why people get pap smears, but HPV can also trigger squamous cell carcinoma. So it sometimes occurs in areas that are not exposed to the sun, but that have been exposed to this virus. Again, we see that in all skin types regardless of sun exposure. Unlike basal cell carcinoma, squamous cell carcinoma has moderate metastatic potential, so it's not as aggressive as melanoma, but if left untreated, particularly certain areas of the head and neck, they can metastasize. So these start somewhat differently from basal cell carcinoma. Squamous cell carcinoma, so when we talk about our skin, the outer layer of our epidermis are squamous cells. So when they start proliferating rapidly, as things do in certain types of cancers, you can translate what you see under a microscope with these overactive cancer cells with thick, scaly skin, because the epidermis is just proliferating very rapidly. So what that means is sometimes these will appear kind of warty, thick, scaly crust. Again, areas like the ears, the lips, these are areas that even in the wintertime are typically exposed just by walking around. And because squamous cell carcinoma is most correlated with chronic sun exposure, this is why we recommend wearing sunscreen on the exposed areas every day, because it's this incremental chronic sun exposure that are very common in these areas. Again, because of the hyperactive epidermis, you sometimes see this thick scale. Sometimes we call these cutaneous horns because they can actually appear like horns growing out of your skin. And usually when you see that really thick, scaly appearance of a skin lesion, that's suggestive of a squamous cell carcinoma. Again, they sometimes are more subtle. Sometimes they are like the patch of dry skin that doesn't go away. A patient might come in and say, I've had this dry patch, but I've tried cream, I've tried cortisone, it's not going away, it's getting thicker. That's often an indication that something needs a biopsy because that could be an SCC, squamous cell carcinoma. And again, similar to basal cells, we like to treat these when they're small and confined to the skin. They can grow so rapidly, they sometimes get infected, they can ulcerate, they can bleed, they can start eating away at deeper structures. So we prefer to treat these when they're still small and easy to cut out. So the last type of skin cancer I'll talk about is malignant melanoma, which is the one that's so important because melanoma, when it's not caught early, can have a very serious prognosis. And my colleagues who are surgical and medical oncologists will speak to you after about how to treat more advanced versions of melanoma. As dermatologists, and this is why the work that Begains do is so important, is because it's really about educating people to use sun protection and also to be familiar with their own skin and to get checked, because even melanoma, which potentially is the most serious, if it's caught early, it's often always curable. So it's really about knowing what to look for. There's been a dramatic increase in melanoma over the past 50 years. It's thought that it's increased 700%. It was thought that in the 1930s, the risk was 1 in 2,500 Americans. Now it's upwards of 1 in 50. Some of this is because we are getting better at diagnosing, so we're diagnosing it more than we were, but a lot of this is a true increase in incidence as well. So it's thought to be the 6th most common cancer. So now this is within skin cancer, where now we're just talking about melanoma. Of the 7 most common, it's the only one that continues to increase in incidence, although recently it's starting to plateau. Something that's really important to understand when we talk about sun exposure and melanoma, unlike the non-melanoma skin cancers, which are more a product of chronic sun exposure, spending time outdoors on the golf course in Florida, melanoma can occur even if someone lives in a place like New York, doesn't get a lot of sun exposure, but they have intense sun exposure at various times through their life. So for example, sunburns directly increase our chance for melanoma. The more we learn about the science of this, there are different types of mutations that can be triggered by intense sun exposure. So sunburns and also indoor tanning beds, which I talked about. Both of those are methods of intense UV exposure that increase one's risk for melanoma. It's thought that even one blistering sunburn during childhood or adolescence doubles your risk for melanoma later in life. So something interesting about melanoma, young women are at increased risk for this disease, but older men actually have the higher mortality rate. So we think that women have a peak of melanoma maybe because they're spending more time getting tan or in tanning salons. After about age 40, the incidence in men surpasses that in women. The trend continues, and older men tend to die more from the disease. Part of it is because women may, I'm generalizing, but women may be better about seeing a dermatologist and getting checked. Oftentimes the men don't present till the melanoma may be more advanced or is more of a problem. So we encourage everybody, regardless of your gender or your ethnicity, to get checked at least once a year. As you heard in the video, 1 person dies from melanoma in this country every hour. Melanoma is the leading cause of cancer-related mortality in young women, although, as I mentioned, older Caucasian males have the highest mortality overall. The good news is, though, that there is still a 99% cure rate. or 5-year survival for those that are detected before they spread. So again, it's very important to try to familiarize ourselves with what melanomas look like so you can hopefully be treated before they have the potential to spread through the body. So here at NYU, there's the Melanoma Cooperative Group, which back in the 1970s came up with ABCD of how to diagnose melanoma. And then when I was a resident here, in the early 2000s, E was added, also out of NYU. So this is like very well known among people. And again, whether you're a dermatologist or a patient or another type of medical practitioner, it's good to familiarize yourselves with these so you know what to look for. But A is for asymmetry. So many forms of melanoma are asymmetric, which means if you draw a line down the middle of a lesion, you don't create matching halves. Whereas for the most part, benign moles tend to be fairly symmetric. So if you draw a line down, like if it's a perfectly round or oval lesion, you'd create 2 matching halves. B is for border irregularity. So again, there are some exceptions, but most benign moles are smooth, round, circular. Borders of melanoma can be jagged or scalloped or notched. So instead of being round, they can have these irregular borders seen here. C is for color variability. Again, there are always some exceptions, but generally speaking, benign moles tend to be uniform, tan, light brown, dark brown. When you start to see various shades, particularly black within a lesion, white, which can mean regression, like your body's trying to get rid of the melanoma. Red can indicate increased vascularity or increased blood supply, which can also make the melanoma more aggressive. So if you see different colors within a mole, that can be concerning. D has been a little controversial within my field recently. D traditionally is for diameter. And for years and decades, it was thought that 6 millimeters, which is the size of a pencil eraser, that if something is growing larger than that, then that's cause for concern. In reality, although that's still true, we've gotten much better at diagnosing melanomas, especially with the use of pocket dermatoscopes, which are magnifiers we use in the office. We often diagnose them while they're much smaller than 6 millimeters, thankfully. So there are some people who are working to try to, I don't have it here, but to have D for darkness. So if someone has, generally speaking, light tan moles and there's one that's jet black, maybe that's an indicator that it should be biopsied. So D is under investigation right now, but we still leave it there. And then E is evolution. And this was the most recent addition, but probably the most important. Evolution means change. So even if a mole, and this is a dermoscopic image. So most of us now use magnifiers to look at individual moles with our eye, but also now there are digital variants of this available as well. But you can sometimes see a very subtle change in a mole. And if a patient comes into my office and they say, I've had this mole for years and recently it's changing, even if it still looks okay to me, if the patient says it's changing, I biopsy it because there's very little downside to doing a biopsy. But if it's potentially a mole that's turning towards melanoma, then the sooner you biopsy that, the better. I do talk about nodular melanoma just to mention it, because as you see, nodular melanoma, which is often jet black, but it doesn't obey a lot of the ABCDEs because it is often uniform in color and quite round and can be symmetric. But when it's jet black and if it's new like this, it's often an indicator of an aggressive type of melanoma. And then I mentioned there was a woman in the video who showed that African Americans sometimes are diagnosed later. They don't get their skin checked as much. There's one type of melanoma called acral lentiginous, which occurs on the soles of the feet. It's very common in patients of color, and so it's worth mentioning because sometimes these get diagnosed much later, and so they can be very aggressive. These are signs of just advanced melanoma. I think even the naked eye could identify, or a layperson could see that these are not good moles. So obviously, hopefully, these would be checked before they get to this stage, but certainly these need to be evaluated. And then this is just more realistic. This is someone I diagnosed a couple years ago in my practice. You can tell that this mole, it doesn't look like those ones I showed that are black and large, but it is definitely asymmetric. It definitely has various colors. The borders are not smooth. So this was an early melanoma. I'm going to let my colleagues talk more about prognosis and management, but suffice it to say that the prognosis of melanoma is directly correlated with the depth of the melanoma. So when we catch melanomas early and they're still quite superficial, they have an excellent cure rate. But if there's a delay in diagnosis, and if the melanoma has potential to start invading into deeper lymphatic vessels and blood vessels, that's when they develop potential to metastasize. So they can be more aggressive. So the key is early diagnosis and treatment. And then I alluded to this, but as far as risk factors, some of the risk factors for melanoma are the same as basal and squamous cell carcinoma, but this intermittent, intense sun exposure that I alluded to, both in the form of sunburns and sun tanning devices, indoor tanning beds, those two risk factors directly increase your chance for melanoma, and that's why we're seeing a lot of skin cancer in young women. And furthermore, people with a lot of atypical moles, also known as dysplastic nevi. So there are people that are covered in these atypical moles, and they can be a real challenge to follow in the practice. I see these patients quite regularly, and we photograph them very regularly as well. But people with these moles are at risk for melanoma developing in the mole, but also de novo in their normal skin. So it's interesting. It's thought that about 3/4 of melanomas occur de novo in normal skin, but about 1/4 or maybe more, depending who you ask. But these moles can actually turn into melanoma, especially if you get a sunburn or sun exposure. So these patients have to be especially careful. So again, sunburns, blistering sunburns, use of sun tanning devices increase your risk for not just melanoma, but also basal and squamous cell carcinoma, which is why we're seeing a lot of these skin cancers even in younger individuals. Ultraviolet radiation has joined arsenic and mustard gas as the highest cancer risk category, and it's linked to more cancers worldwide than any other carcinogen, and that's including cigarette smoking. So we really want to encourage people to wear sunscreen, use sun protection, and get checked. I'm going to go through some of this. So basically the issue is, what can you do? So we're talking about how can you protect yourself. This is like the most important take-home message here, is that contrary to popular belief, only approximately 25% of your lifetime sun exposure occurs by age 18. So people often say to me, I used to not be careful, I never wore sunscreen, I used baby oil, it's too late. And I always encourage them, it is not too late. In fact, out of Australia, they've done a lot of good research that even following people later in life, in their 60s and above, if you start wearing sunscreen every day and avoid sunburns, it decreases your chance of skin cancers, of brown spots, of aging. So it really is never too late to make a difference. You want to try to avoid peak hours of sunlight when the sun's rays are strongest. Use a daily sunscreen on exposed areas. Wear sun protective clothing. These are my children when they were younger, but basically teaching children sun protection early. Even my boys who are now teenagers on the right, when I tell them to go put their bathing suit on, they grab a rash guard or a swim shirt too. So the sooner you can teach them that, the better. Avoid tanning salons. Again, these sun lamps emit UV radiation that can be 12 times more powerful than even midday Miami sun. So you want to make sure, we're trying to legislate this and certainly not allow youth in them, but I think they should be gone altogether. Sunless tanners are a safer option. If people like to look tan, then they can get it in a bottle, as long as they still use sunscreen. Get vitamin D through a healthy diet. Examine your skin regularly. And most importantly, if you notice any changes, see a dermatologist promptly, because skin cancer can be preventable and curable when it's detected early. So thank you for your attention, and I'll now turn it over to my colleagues.